a lot of the same questions. So hopefully, if we can go back and clear up some of the things, I think a lot of people are confused on the same concepts. And yeah, if those were more clear, maybe things would start to click a little more. It's just this material is something that it may take a dozen passes before you start to make those connections. So don't give up on it. All right, let's get started. Okay. So I pulled some stuff out of first aid because I thought some of her lecture material on this wasn't maybe the clearest. Or I think first aid simplified it a little bit more. So as far as all of these pathways that are neuro related, don't go crazy right now trying to understand the minor details. She's not going to test you on that. It's going to be, focused on the pharmacology. So as long as you have a basic understanding, you'll be fine for this exam. Dr. Leo, I think I don't know, it might be on the next exam. I don't think it's on this first exam, but Dr. Leo goes into great detail on the difference between Parkinson's and Huntington's and the pathways involved in that. So right now, don't stress out about going too crazy with those. So, in my opinion, if you know what first aid presents here, that's enough for now. So let's go through it. So you have 4 dopaminergic pathways. So the first one is the mesocortical pathway. And the mesocortical pathway is going to project from the VTA to the cortex. So if you have a decrease in dopaminergic activity in the mesocortical pathway, that increases the number of negative symptoms associated with the schizophrenia that the patient's going to present with. Where in the mesolimbic pathway, if you have an increase in dopamine, you have an increase in the number of positive symptoms. So when we say positive symptoms, you're referring to things like delusions and hallucinations. And when you talk about negative symptoms, it's stuff like inertia, apathy, or lack of spontaneity. So the only thing that you really need to understand right now is that when you have plenty of dopamine in the mesocortical pathway, you inhibit the mesolimbic pathway. So if you have a decrease in dopamine in the mesocortical pathway, you're disinhibiting the mesolimbic pathway. So not only will you see the negative symptoms, but you'll also see the positive symptoms of schizophrenia. Yeah. So understand the difference between positive and negative symptoms and the result of increase or decrease in dopamine and its effect on the presentation of those symptoms. So in the nigrostriatal pathway, this is the pathway that's related to Parkinson's. So if you have a decrease of dopamine in the nigrostriatal pathway, then you're going to have extrapyramidal symptoms. So things like dystonia, akathisia, Parkinsonism, tardive dyskinesia. And then in the tuberoinfundibular pathway, when you have a decrease in dopamine, you have an increase in prolactin. So that precipitates in things like decreased libido, sexual dysfunction, galactorrhea and gynecomastia in men. So something that is tested on a lot is if you have a male patient that presents with gynecomastia, or say a female patient with galactorrhea, like excessive nipple discharge, one way to treat them is by giving them a dopamine agonist. So if you increase the amount of dopamine in the tuberoinfundibular pathway, then you're going to have a decrease in the amount of prolactin, and then that should fix the galactorrhea. Okay. Okay, so the pathways associated with Parkinson's and Huntington's, like I said, you're going to go in a lot greater detail in neuro. But right now, if you understand the neurotransmitter excess or deficit that comes along with those pathways, then that'll be fine. So dopaminergic neurons that originate in the substantia nigra, they normally inhibit GABAergic output from the striatum. So whereas cholinergic neurons, they normally exert an excitatory effect. So in Parkinson's, if you don't have enough dopamine, this is why you see the rigidity and the bradykinesia that's associated with Parkinson's. It's because you're losing the inhibition of the GABAergic neurons. So you have excess GABA, and that gives you that rigidity that's associated with Parkinson's. Okay, yeah, so here it shows, Parkinson's, excess of acetylcholine, lack of dopamine, and then lack of serotonin. But I would focus on GABA and above. And then in Huntington's, you have excess dopamine, so you have loss of GABA inhibition, because what happens if you're inhibiting an inhibitor? So if you're inhibiting GABA, you're not getting inhibition. And that's why in Huntington's, you're going to see those choreoathetotic movements instead of the rigidity. All right. So direct dopamine agonists, she did, in the old recording, she did ding ding phenoldiprem. So phenoldiprem is a D1 agonist, which does what? What do D1 agonists do in the body? Vasodilation or vasoconstriction, right? So vasodilation in the renal mesenteric arterial beds. So this is used to treat a hypertensive emergency. And then also you have bromocriptine and ropinirole. Like she said, she's really not focusing on uses unless she points them out. But like I pointed out in the first slide, if you don't have enough dopamine, you have an increase in prolactin, which leads to galactorrhea. So one way to fix that is by giving a dopamine agonist. So by giving a dopamine agonist like bromocriptine, you decrease the amount of prolactin. And then, of course, you reverse these side effects. Okay. The only other thing that she had in red were some adverse effects related to dopamine agonists. So those would be hallucinations, psychosis, impulsivity, and addiction. Okay. So I'm going to start here with bupropion. So bupropion is a dopamine reuptake inhibitor. So you're inhibiting the reuptake of dopamine, therefore increasing the amount of dopamine in the synapse. So this is used to treat depression, and when it's being used to treat depression, it goes by the name bupropion, but it's also used to treat smoking cessation. And when it's being used for that, it's the same drug, but it goes by a different name, and that name is Zyban. So, oops, sorry about that. Okay, so one of the important adverse effects, which I do remember being on the exam last year, is the fact that if you give a patient bupropion, like for example smoking cessation, there's an increased risk of seizures. So if you have a patient who wants to try to quit smoking, and your options are, and they also have a history of seizures or maybe even an eating disorder, and your list of options are varenicline, bupropion, a full nicotine agonist like the transdermal patch, then you're not going to choose bupropion. You would choose one of the other two. And in fact, bupropion is far less popular than the other smoking cessation options for that reason, for the increased risk of seizures. And also, I don't think she actually listed it, but one of the reasons that you don't want to give this to a patient with a history of an eating disorder is because bupropion can actually assist in weight loss. And you guys might be familiar with the drug Contrave. So Contrave is like a popular weight loss drug right now, and Contrave is actually a combination of naltrexone and bupropion. So if you can remember that, or if you're familiar with Contrave, hopefully that'll help you remember that one of the adverse effects of bupropion is weight loss. So you don't want to give that to somebody with a history of an eating disorder or with a history of seizures. Okay, and then we also have levodopa, which is given with carbidopa, and this is used to increase dopamine synthesis. So its big use would be to treat Parkinson's disease. So levodopa is given with carbidopa to prevent peripheral conversion of levodopa to dopamine. And so, like, why is that important? Why would you want to prevent peripheral conversion? Like, what is the target of this drug? Obviously, it's not the periphery. Where is it trying to go? Right. You want it exactly. You want it in the CNS. So you want to make sure that you're getting it there before it's metabolized in the periphery. So, and this is important, but she didn't ding it, or at least last year. Two ways to decrease the efficacy of levodopa would be to give it with vitamin B6 supplements because it increases the peripheral conversion of levodopa, or to give it with high protein meals because the protein, I guess, competes with the drug transporters. Okay, and then the last two important indirect dopamine agonists would be phenelzine and selegiline. So selegiline, at least in the exam world, is the one that they tend to talk about more. And this is because it carries an adverse effect of serotonin syndrome. So if selegiline is an MAO B inhibitor, why would it cause serotonin syndrome? what would an MAO inhibitor do? Like what, right, prevents the breakdown of what though? MAO inhibitors prevent the breakdown of catecholamines, right? So dopamine, norepinephrine, and serotonin. So if you're inhibiting the breakdown of those catecholamines, you could end up with an excess of serotonin, therefore leading to potentially serotonin syndrome. So basically, anything that gives you, uh, you know, an excess or potential buildup of serotonin has the potential to lead to a serotonin syndrome. So that's why you see that as an adverse effect that's associated with so many drugs. Alrighty. Okay, so with our D2 blockers, more important than knowing the uses is going to be knowing the potential adverse effects. So D2 blockers are going to decrease dopamine in the mesolimbic system. So you treat the positive symptoms of schizophrenia, but not the negative symptoms of schizophrenia. In order to treat the negative symptoms of schizophrenia, you need something like a serotonin antagonist that's blocking the serotonin in order to increase the dopamine in the mesocortical pathway. Because if you increase the dopamine in the mesocortical pathway, then you treat the negative symptoms and you also shut off the mesolimbic system, which also treats the positive symptoms of schizophrenia. Okay, so a few important side effects. If you give a D2 blocker, that can lead to extrapyramidal symptoms. So your Parkinson's-like tremor, so that's that pill rolling tremor, or a perioral tremor, so just like it says, around the mouth, or akathisia, which is the inability to sit still, or dystonia, which includes things like an oculogyric crisis or torticollis. Do you guys know what an oculogyric crisis is? No? Anybody? So an oculogyric crisis just means that the patient's eyes roll into the back of their head. Like the patient's eyes move upward. So if you've heard that phrase, their eyes rolled into the back of their head, that's an oculogyric crisis. Okay. The two most important ones, though, that she dinged on Mediasite is the fact that dopamine blockers can lead to hyperprolactinemia. So, again, on that slide, I guess it was the first slide, that chart is super important. So, decrease in dopamine is going to lead to an increase in prolactin, and that's going to manifest as things like gynecomastia, swollen or painful breast in women, and then galactorrhea in either men or women. Okay, so the last one, which is neuroleptic malignant syndrome. This one is really important. So if you give someone a D2 blocker, basically one of the effects can be this syndrome. And it's just kind of something that you have to memorize. So it can result in altered mental status, elevated temperature, what's called lead pipe rigidity. So basically, it's just, describing it. They're extremely rigid, basically. Hyporeflexia and autonomic instability, including a fluctuating blood pressure or elevated respiratory rate. So did she talk about how to distinguish neuroleptic malignant syndrome from serotonin syndrome? they're kind of like two things that you would look for. Because sometimes if you're reading the presentation of neuroleptic malignant syndrome in a STEM, it's easy to confuse it with serotonin syndrome because they look really similar. So do you know what you would look for? Okay, so with neuroleptic malignant syndrome, it presents very similar to serotonin syndrome with two exceptions. So with NMS, you're going to see, yeah, they are, but kind of two things more in like the physical exam that gives it away. So with NMS, you're going to see the lead pipe rigidity and then hyporeflexia. With serotonin syndrome, you're going to see clonus, which is like a rhythmic contraction of the muscles, and hyperreflexia. Um, so that's kind of something that they would have to give you in a question stem to tell the difference. I mean, they may or may not say they're agitated, but they would definitely tell you about muscle rigidity and their reflexes. Okay, metoclopramide. She didn't really stress this. You know, if you know it's a D2 blocker and it promotes GI motility, that should be good enough. And then I would also just know that haloperidol and these other two are D2 blockers, and they are considered typical antipsychotics or your first gen antipsychotics. The one that I would hope or think that you were most likely to see on the exam would be haloperidol. That's one that's commonly used. All right. Okay, so next are your atypical antipsychotics. And the big thing that she focused on here, well, two big things, and they're both adverse effects related to these atypical antipsychotics. So the first one is the potential for weight gain. So with clozapine and olanzapine, one of the adverse effects is a weight gain. So in first aid, it has a little trick to help you remember that you're at risk for obesity and clozapine and olanzapine. So if you just remember the big O's associated with obesity. And then the second thing she talked about is that clozapine is usually given as kind of a last ditch effort. And the reason for that is that in order to get the prescription, a patient has to have a CBC regularly, and that's to monitor for neutropenia or agranulocytosis. So you monitor clozapine closely. And this was definitely a question in second year too, so I would say both of those points are probably highly likely to show up on your exam. Okay, what else? Oh, okay. So one advantage of using a D4 blocker, which also blocks serotonin. So what is one advantage of using one of these atypical antipsychotics over the typical antipsychotics that only block D2? So basically, so let me ask this a different way. So when you're treating schizophrenia, what is the advantage of blocking serotonin instead of blocking just dopamine and the mesolimbic pathway? So if you block dopamine and the mesolimbic pathway, what are you treating in respect? Well, in respect to schizophrenia. Yeah, so if you're using a D2 blocker, you're targeting the mesolimbic pathway, so you're only treating the positive symptoms of schizophrenia. Whereas if you use a drug that also blocks serotonin, by blocking serotonin, you're increasing the amount of dopamine in the mesocortical pathway, so you're treating both the negative and the positive symptoms of schizophrenia. Okay, the last one, and this one comes up a ton in board practice questions, and it also was a test question in the repro course. So if a patient is being given lithium to treat his or her manic phase of bipolar depression, and especially if that patient happens to be a pregnant female, one of the adverse effects is something known as Ebstein's anomaly. So do you guys remember that at all from anatomy? At least like the description of Ebstein's anomaly, what it looked like in the heart? Like how would you describe it? Right? Something to do with the tricuspid valve. So kind of a common phrase to describe Ebstein's anomaly is if you see atrialization of the tricuspid valve, that's definitely kind of like a buzzworthy phrase that should clue you into Ebstein's anomaly. So atrialization of the tricuspid valve or displacement of the tricuspid valve. So if you think of, what's in the right atrium, then you can kind of make sense of why this can be fatal because of the antiarrhythmic effects of that anomaly. But then she also put in red that hyponatremia increases lithium reabsorption in the kidney, so therefore it increases the risk of toxicity. But I've definitely seen the Ebstein's anomaly question more than I've seen this, but I don't know. I guess on the exam it could be one or the other. Honestly, don't remember from last year. Okay, so a couple of quick practice questions. 21-year-old female with an undiagnosed eating disorder presents to the ED with new onset seizure. The patient has an 8-pack year smoking history. Her mom says she was recently prescribed a medication for smoking cessation. Which of the following medications was she likely prescribed? Right, good job. Bupropion. Yeah, so don't forget that risk of seizures when you prescribe bupropion, especially in a patient with a history of eating disorders. Okay, what is the rationale for combining levodopa with carbidopa? Right, and I realized I mismarked it here. B is the correct answer, so I will fix that before I post these. I read it as inhibits, but yeah, B is correct. So good job. Okay, a 25-year-old Gravida 1, Para 1 woman presents to the clinic for a follow-up. She has a well-documented history of bipolar disease for which she takes lithium. Which of the following potential cardiac relevant teratogenic effects does lithium have on the fetus? Right. So D, displacement of the tricuspid valve, known as what? Right, Epstein's anomaly. Good. Okay, so moving on to the serotonin lecture. All right, so I don't think she's going to test on melatonin because she didn't have anything in red related to it, but just to go over it quickly. So out of first aid, melatonin is synthesized from serotonin. Um, it induces lightening of pigmentation of skin cells, suppresses ovarian function, improves the quality of sleep. If you add exogenous melatonin when endogenous levels are low, it can reduce sleep latency and improve sleep quality. Um, so the only reason this is important is because people who take melatonin to sleep when they actually don't have a deficiency of melatonin, it's not going to be effective for them. So the melatonin receptors, MT1 and MT2, are related to sleep. And then the third one mediates the effects of melatonin on the peripheral glands. So if you know the function of the first and second one, then you can kind of infer from that Romeltion, which is an MT1 and MT2 agonist, is going to be used to treat insomnia that's associated with delayed sleep onset by targeting these two. All right, and of course, melatonin is not prescribed. It's just simply a dietary supplement that a lot of people use to help them sleep. Okay, so getting to the important stuff. So in this case, I would know the receptor subtype for serotonin, at least to the extent of what's on this chart. I mean, there are a lot more out there than this, but I would at least pay attention to this chart and know the subtypes. So outside of the CNS, most of your serotonin is produced in the GI tract. It helps with smooth muscle contraction, and in the area postrema, it contributes to nausea and vomiting. And then also it aids in platelet aggregation because platelets both take up and store serotonin. So anything that inhibits serotonin reuptake comes with a risk of bleeding because you're losing the serotonin present in your platelets. Okay, so I think this chart is nice. So this is straight out of Dr. Babos' slides. Hopefully it was in this year's PowerPoint too. But this is pretty much everything that you need to know related to serotonin right here. So the receptor type 1A, there's a drug called buspirone, and it's an anxiolytic, so it's used to treat anxiety. And then 1B and 1D are used in migraine treatment, and that's due to the vasoconstriction that they promote. And then receptor subtype 2, so 5-HT2, if it's an agonist, it's used as an antidepressant, which is trazodone. And you guys remember the important adverse side effect associated with trazodone? Right, trazodone, trazoboner, yeah. Yeah, so it's associated with priapism. And then on the other side, a 5-HT2 antagonist, clozapine and olanzapine. So those are the two that can lead to weight gain. And then finally, your third one, ondansetron, it's a antiemetic because it targets the chemoreceptor trigger zone. Okay, so your direct serotonin agonist. So again, this is where if you know the receptor subtypes, it kind of helps you remember the function of the drug. So your 5-HT1B and 1D agonists are your triptans, and the one that she said you need to know is sumatriptan. So sumatriptan is used to treat chronic migraines, and that's through vasoconstriction of the CNS vascular smooth muscle. So a drug that is promoting vasoconstriction, obviously you want to avoid that in anyone with coronary artery disease or basically any condition that puts you at risk for ischemia. Because you obviously wouldn't want to, promote further vasoconstriction. Okay, and then your 5-HT2C agonists. So the important one here is locazepin, and this is used for weight loss. And it does so by increasing satiety by turning on POMC and CART. So your 5-HT2C antagonists, what were those? So two that were promoting weight gain rather than weight loss. The big O's. Right, so clozapine and olanzapine. So if you can associate, locazepin and clozapine and olanzapine, just remember that clozapine is helping with weight loss through promoting satiety, while clozapine and olanzapine run the risk of weight gain. Okay, so 5-HT4 agonist, that's tegoserod, definitely more low yield compared to these two. And it's used to treat constipation because you're promoting gut motility. And then I honestly don't think I would worry about these. I don't remember her testing on those, and she didn't have anything in red. Okay, so here we have our SSRIs, and those are used to treat depression. I think most people have heard of, SSRIs. So two examples are fluoxetine and sertraline, and they come with adverse effects that include sexual dysfunction and manic activation. So both of those she had in red. Sexual dysfunction is a really common one, so which I'm sure you've probably heard of, people taking antidepressants. Common, very, very common side effect is sexual dysfunction. And I think they actually consider that the most common reason for discontinuation. So I know in second year they talk about, that's something that you always want to ask about, even if it's not mentioned, because most patients tend to be more hesitant to bring that up, but if you ask them about that, they're more likely to tell you. So also, something she put a bunch of stars around, at least last year, was the fact that the drugs that have a longer half-life, there's less of a risk of withdrawal. So your risk of withdrawal in norfloxacin is going to be less than fluoxetine because it has a longer half-life, or at least the severity of the withdrawal will be less. And then, of course, again, serotonin syndrome. So if we look at the mechanism of action, a serotonin reuptake inhibitor, inhibiting the reuptake of serotonin, so which leads to potentially an excess of serotonin, especially if you combine it with another drug that promotes the amount of serotonin. So again, serotonin syndrome. And I do have more about that on the next slide, so I'm going to put a pin in that for now. One thing that was definitely, I remember being on the exam last year, So Dr. Babos, loves plants, so anytime she can put anything related to that to the exam, and this is actually, um, highly board relevant too. So St. John's wort is an enzyme inducer, um, and one of the common drug interactions would be a patient taking oral contraceptive pills and also taking St. John's wort, because I believe it's something that you can just get over the counter. They may end up with, an unintended pregnancy, not realizing the interaction that exists there, because taking St. John's wort and birth control at the same time, it's going to induce the metabolism of your birth control pills. So St. John's wort would be something to avoid in that case. Okay, so SNRIs, just focus on the mechanism of action here and which drugs fall into that category. So 2 examples would be venlafaxine and duloxetine. And so if it helps you remember, these are commonly used in veterans. And the reason for that is if someone is suffering from depression and they also have pain, like for example, they have some sort of, injury from serving, then this is all like often a first choice, because not only is it going to treat their depression, but it's also good for pain management. So you're kind of like killing 2 birds with 1 stone there. She did have 4 adverse effects in red, so insomnia, hypertension, tachycardia, and anorexia. And those are predictable, because not only are you inhibiting the reuptake of serotonin, you're also inhibiting the reuptake of norepinephrine. So you can think about how that relates to all of those sympathetic pathways. And then your tricyclic antidepressants, just based on what they told us in second year, apparently these have kind of fallen out of favor. And the reason for that is because they come with a very large side effect profile. So I don't think there's really any need to memorize, exactly what they're doing, but, just know that amitriptyline and nortriptyline fall into the category of tricyclic antidepressants. And then, oops, sorry about that. So I don't, somebody can correct me if she made a big deal about this and Collaborate, but it's definitely high yield to know that you treat a tricyclic antidepressant overdose with bicarb. So that's something that you really want to know for boards, but for whatever reason, I don't think she's choosing to test you on that this year at least, but kind of keep that in the back of your mind. She mentioned it but didn't harp on it. Okay. Yeah, just kind of keep it in the back of your mind. That is a very high yield point, though. Sodium bicarb to treat tricyclic antidepressant overdose. So anytime you see an antidote for an overdose, that's something that is very important as far as boards go. Okay, serotonin syndrome. Really, I think, first aid does a good job of summing it up. So if you remember the 3 A's, increased neuromuscular activity, so that's when I was talking about the hyperreflexia and the clonus, that's serotonin syndrome. And then NMS, the neuroleptic malignant syndrome, you're looking at hyporeflexia and lead pipe rigidity. So any sort of like practice question, that should be kind of a dead giveaway. Am I dealing with NMS or am I dealing with serotonin syndrome? Then you also get the autonomic stimulation and the agitation, but I would definitely kind of focus on the neuromuscular effects when you're trying to differentiate those two. And then also the history, of course, but if somebody came in with these symptoms and they were by themselves, you wouldn't be able to rely on the history. Okay, so partial serotonin agonists, buspirone. She didn't make a big deal about this, so I'd say low yield, but help you remember for boards. The trick in first aid is that I'm always anxious if the bus will be on time, so I take buspirone. So remember your um, 5-HT1A, those are anxiolytics, so buspirone is used to treat anxiety. And then also, the second one here is your serotonin partial agonist reuptake inhibitors. So the big one to know is trazodone, which is used to treat insomnia that could be caused by other antidepressants. And then the adverse effect that she ding-dinged was priapism. So trazodone, think trazobone. And that was on my first like practice ComBank that the school made us take. This right here, that was on it. Okay, serotonin antagonist. Um, so the ding ding, the one I would know, would again be clozapine and olanzapine. So these are atypical antipsychotics with the adverse effect of weight gain. So if you remember the cloze and the is it high yield that she mentioned buspirone must be taken for several weeks? I mean, it's important, I guess, but I don't think that's something that she would test you on this year, at least. Yeah, no problem. But yeah, she's definitely gonna get you here. So remember your 5-HT2A and C antagonists, clozapine and olanzapine, can lead to weight gain. So the big O's associate with obesity. All right, practice questions. A 28-year-old female presents to the clinic with right lower quadrant pain. The patient says she's not, that should be pregnant, as she is taking oral contraceptive pills, but you talk her into a urine pregnancy test just to be safe. The test comes back positive. She says she started taking St. John's Wort because she's been feeling down since the quarantine. So her unintended pregnancy is likely due to which of the following? Right. So the fact that St. John's Wort is an enzyme inducer. Sorry, I couldn't come up with four options, but I do remember this on the exam last year. It was kind of like one of those give me questions. So questions like this, you want to make sure you can get because, the stuff from last week is definitely a lot more tricky. And oh, another thing. Okay, so I haven't looked to see if she's put them out yet, but the practice questions that she puts out to cover the material that was last week, like all the autonomic stuff, I remember just absolutely panicking before the exam because I thought those practice questions were like incredibly difficult, and I was like, oh no, I'm not ready. But I found that her practice questions were much, much, much more difficult, at least the autonomic ones, than the exam itself. And when I was re-listening to the recordings today, she did say that she does that on purpose because she'd rather you get it wrong now, like make the practice questions extra hard now, and you get it wrong than you went on the exam. So like just don't anybody totally freak out if you find her practice questions very difficult. I thought the exam was a lot more doable. Okay, so a 40-year-old male presents to the ED with an erection lasting longer than 4 hours. He says he recently started taking a new med for insomnia, but can't remember the name. Which of the following medications is he likely taking? Right, good job. So trazodone, trazobone. Okay. pharmacology of GABA. So I believe Dr. Weaver, do we need to know any other uses of trazodone? No, I would just focus on the adverse effect. Yeah, I would say overall the uses are not near as important as understanding like the mechanism of action and the adverse effects related to all these drugs. Okay, so relationship between GABA and glutamate and isoniazid. So I know Dr. Weaver covered this. Did she actually test you on it on the exam? Like the adverse effects of isoniazid? Was that on your last pharm exam? Do you remember? The only reason I'm asking is because if it didn't show up last time, you don't remember. Yeah, that's okay. I'm only asking because if it didn't show up last time, I'm kind of betting that it will this time. But if it was on there last time, they're less likely to test you on it twice because they don't want to waste a question. Okay, but anyways, so isoniazid is going to deplete pyridoxal 5-phosphate, which is the active form of vitamin B6. And the way it does this is, for one, isoniazid is going to form complexes with pyridoxine and then eliminate it. And then also it's going to target pyridoxine phosphokinase, which is going to inhibit the conversion of pyridoxine to its active form, which is important for converting glutamate to GABA. And also it targets glutamate, I believe this is, glutamate dehydrogenase, I believe. It's also going to target that enzyme, so it's kind of getting you in 3 places here. But overall, leading to a vitamin B6 deficiency. So last block, Dr. Weaver talked about supplementing isoniazid treatment with vitamin B6 in order to prevent what adverse effect? Well, not only seizures, but there was kind of a big point that Dr. Weaver talked about. So, right, Amy. So, peripheral neuropathy. So you want to supplement with vitamin B6, not only to prevent seizures, but also to prevent peripheral neuropathy. So in malnourished patients, seizures may occur due to loss of GABA, and that's because you don't have this activated vitamin B6 to facilitate the conversion of glutamate to GABA. So of course, glutamate is an excitatory neurotransmitter, so that's going to, potentially precipitate in seizures for the patient. But this overall is a pretty high yield point, so I would definitely have this down for the exam. Okay. Okay, so GABA A agonist. Did she talk about the whole Barb likes it long, Ben likes it fast? Did she mention that and collaborate? Yeah, so one thing you want to remember. Oh, really? Okay. So has she not covered the GABA lecture yet? Oh, okay. Well, that's okay. I don't have very many slides on this, so at least if I point out the high yield stuff, like you'll know what to focus on when she does give the lecture. Okay, so I'll just assume that I won't ask if you guys know anything yet then, since she hasn't covered it. Okay, so Barb likes it long, Ben likes it fast. And This is referring to the mechanism of action of barbiturates versus benzodiazepines. So you went from tutor to professor. Okay. Yeah. Yeah, you guys, man, you have no idea. I'm actually like an extremely like introverted and shy person, so this whole tutoring stuff, I'm like sweating bullets sometimes. Okay, but anyways, so um, barbiturates are gonna bind to the GABA A receptor, and they increase the duration that GABA A chloride channels open in the open state. Thank you, I appreciate that. They increase the duration that the GABA A chloride channel is in the open state, so even in the absence of GABA. So this is where the barb likes it long comes from. It's because you're increasing the duration, whereas um, with benzodiazepines, they bind to the GABA A receptor and they increase the frequency with which the chloride channel is in the open state, and that's only in the presence of GABA. So that's where you're getting the bin likes it fast, because you're increasing the frequency um, versus the duration. And let's see. So she also wants you to know that barbiturates are enzyme inducers. So of course that leads to a lot of potential drug interactions. But just for now, know that they're enzyme inducers along with your St. John's wort. And then, okay, so benzodiazepines are used as anticonvulsants, and then they're also used as anesthesia. And so, one important thing to know, I don't know if she'll really focus on it this year. Definitely the seizure aspect is more important, but this should help you remember the fact that benzos are used for anesthesia. So they cause anterograde amnesia. So that means you're not going to remember what happens right after you give the benzo. So a lot of times um, they'll give chemo patients, especially if they're children, they'll give them a benzodiazepine to treat anticipatory nausea and vomiting related to chemo. So, if they're able to give them this prior to chemo or cancer-related treatment, sometimes you can mitigate, that anxiety or nausea and vomiting that's related to those treatments. Okay, okay, so here we have an antidote for benzodiazepines. So anytime you have an overdose, knowing the antidote, that's always very important as far as boards go. So if you give, and I think she actually dinged this one, so for sure know it. So if you have someone who overdoses on benzos, you're going to give them flumazenil. However, when given flumazenil, this can precipitate seizures in someone who's dependent on benzos. So in the exam world, you're always going to give flumazenil. However, in the real world, you're probably not going to give this antidote, especially to an adult patient, because a benzo overdose is very unlikely to kill you. However, status epilepticus, a seizure, that can kill you. So it's kind of like a risk versus reward thing. The risk with giving the antidote is definitely much higher than the risk of not giving it and allowing the patient to recover, because, like I said, a benzo overdose is less likely to kill you, and that has to do with the mechanism of action. She mentioned, or she's going to mention, the fact that a barbiturate overdose is much more deadly, and that's because you're increasing the duration of the opening of the chloride channel. Um, so yeah, the only time I think in the real world, or at least according to Dr. Bevis, that you would give flumazenil is like say you had a 3-year-old that got into their grandparents' medicine cabinet and took the bottle of benzos, then you would go ahead and give the flumazenil because chances are a 3-year-old's not benzodiazepine dependent, so you don't have um, that risk of precipitating a seizure. So in that case, the risk versus reward would be worth it if you were talking about a small child like that. All right. So another very high yield point is the fact that the 3 benzos that are safe in liver dysfunction or hepatic disease are going to be oxazepam, temazepam, and lorazepam. So I think Dr. Babo says other than liver, but everybody else says out the liver. But either way, so OTL, these 3 are the safest choice in a patient with hepatic disease. And then the one most commonly used in ethanol withdrawal is going to be lorazepam. Okay. Baclofen, she more or less, she definitely brushed over this. So other than knowing it's a GABA agonist and, it's used in motor neuron disease, I definitely wouldn't worry too much about this one. Definitely low yield, at least for this exam. Okay. So ethanol. So first of all, knowing that your first choice in an alcoholic with, say, hepatic disease is going to be lorazepam. So that's important. And then also the fact that you want to give the patient thiamine if you're giving them dextrose. So, and the reason that you do that is that, so I have it outlined right here in red in first aid. So, ATP depletion, that's worsened by glucose infusion. So by dextrose, I mean glucose. So and in alcoholics and malnourished patients, yeah. So here's the big ding ding. Give thiamine before dextrose to reduce the risk of precipitating Wernicke's encephalopathy. And this has to do with that ATP depletion. All right. The last one here is ethylene glycol and methanol poisoning. The thing that makes this easy is that whether it's antifreeze or methanol, you're going to treat it the same way. So you'll give fomepizole or ethanol, and that's going to inhibit alcohol dehydrogenase. So basically, by inhibiting that enzyme, you're preventing the downstream metabolites, which can be very toxic. Let's see. Okay, so methanol, what you want to know here is that one of the breakdown products, formic acid, this targets the optic nerve. So this leads to what they call snow blindness. So this is kind of like blurry vision, I guess. And then on this side, I believe it is oxalic acid. This is what it's going to chelate calcium. So that's going to lead to hypocalcemia and then crystalluria in the urine, which basically just means when you do your urinalysis, they're going to see the presence of rhomboid-shaped crystals under microscopy. And basically, the reason this is important is because if you have someone with hypocalcemia, that can result in tetany. Okay. Couple questions, and then we'll be done. All right, so 35-year-old male patient who is homeless develops new onset tonic-clonic seizures. He recently started 4 drugs to treat a pulmonary infection caused by acid-fast bacterium. A decrease in which neurotransmitter is responsible for his seizures? Right, so the correct answer here is B. And, so basically this is right out of her lecture. I just changed, the final question a little bit. But by saying he has a pulmonary infection with an acid-fast bacterium, they're referring to TB. So what drug was he likely taking? Right. Isoniazid. Okay. So next question. 40-year-old male patient was given a drug that binds to a subunit of the GABA A receptor. When used at a high dose, it can open chloride channels independent of GABA. So what drug was he given? Right, so phenobarbital, so make sure you know the whole Barb likes it long, Ben likes it fast, and the mechanism of action of Barbs versus benzos. Okay, a 50-year-old male patient presents with the ED unresponsive. His wife says she found him in bed when she got home from work and was able to wake him up. You get a CMP and discover the patient has hypocalcemia, and urinalysis indicates the presence of rhomboid-shaped crystals. Which should you give to treat the patient? I should say what should you give. I gotta fix a lot of these. Right, good job. So you're gonna give fomepizole. Yes. All right. Yeah, she's definitely more straightforward on the lectures that come from this week. That way, so you can focus on the autonomic stuff from last week because she knows that's really difficult, especially the first time around. So, yeah, this week I would focus, almost solely on her ding dings, and then, spend more of your time on all that really tough stuff from last week. Do you know of any resource for dopamine? Ooh, do you have the BRS Neuro book? Or it could be in the BRS Farm book too. But I would say that stuff's probably for sure in the BRS Neuro book. Do you have a copy of that? Yeah. Okay, so if you block serotonin, another explanation of yeah, absolutely. Okay, let me go back to the slides. Yeah, and I was looking for a good picture of those pathways that didn't give you like all of the specific areas in the brain, and I just could not find one. Okay, so too far. Here we go. Okay. So, in the mesocortical pathway, if you have a decrease in dopamine, that's going to lead to the negative symptoms. In the mesolimbic pathway, if you have an increase in dopamine, that's going to lead to positive symptoms. So that's where you want to start. In order to treat this, by increasing dopamine in the mesocortical pathway, you're going to get rid of the negative symptoms, but you're also going to put the brakes on or inhibit the mesolimbic pathway, which she calls the monkey brain. Okay, so any drug that is just targeting the mesolimbic pathway, so like your D2 blockers, you're getting rid of the positive symptoms of schizophrenia, but you're not doing anything to treat the negative symptoms. And of course, the positive symptoms tend to be, more disruptive, I think, to a patient's life. So that's important. But if you want to treat both, no problem. If you want to treat both the negative and the positive symptoms, you would want to give something that blocks serotonin. So by blocking serotonin, you're going to increase the amount of dopamine in the mesocortical pathway, which is also going to inhibit the mesolimbic pathway. Does that help? Right, so basically the mesocortical pathway keeps the mesolimbic pathway in check as long as you have enough dopamine. But once once that level of dopamine goes down, then the mesocortical pathway can no longer keep an eye on the mesolimbic pathway, and it disinhibits it. So not only do you get problems in the mesocortical pathway, now your monkey brain is going crazy. But just the important thing to get here is that, whether dopamine is decreased or increased is different as far as what symptoms precipitate from that. So lack of dopamine in the mesocortical pathway leads to negative symptoms. Increase in dopamine in mesolimbic leads to positive symptoms. Are the 5-HT2C antagonists the drug? Yes, and that's why using those drugs is advantageous. So if you block serotonin, you're increasing the amount of dopamine in the mesocortical pathway. So by doing that, you're also inhibiting the mesolimbic pathway, so you're treating both negative and positive symptoms. However, your serotonin antagonists come with, a larger side effect profile. So it's kind of a risk-benefit thing, I think, that you have to weigh there. Any other questions? Mine? Oh, sorry. Why wouldn't just increasing dopamine in the mesocortical pathway cause a decrease in dopamine in the limbic system? Because it's my understanding that your D2 agonists, they target the mesolimbic pathway. So that's why, it's not going to work, because you're targeting the mesolimbic pathway. There's no direct agonist of dopamine for the cortical pathway. I don't. I mean, here it says antipsychotic drugs have a limited effect, so I don't know that it's that one doesn't exist over that they're just not as effective. But I mean, that's something that I would have to look up. I'm not totally sure. Hold on, just 1 second. Um, is that the drugs that are the same as the? Well, they so the 5-HT2C antagonists, they are also D4 antagonists, and I know she had this in her lecture, so I'm trying to. I forgot specifically what D4 targets. Trying to look that up right now. See if I can find this lecture. Oh, I can't open your screenshot. Did you find it in her lecture by chance? It's not gonna let me open it. Yeah, let me know what screenshot you're trying to send me. It increases dopamine in the mesocortical and nigrostriatal. The D4. Yeah. EPS means extrapyramidal symptoms. Yeah. Thanks for your help there. And again, I wouldn't get too worried about those pathways. Like, that's something that is definitely more for neuro. Just, knowing the mechanism of action of the drugs, and then, those adverse effects that she dinged. That'll definitely cleared a lot up. Okay, good. Hopefully I didn't cause more confusion. You're welcome. And no, the second pass explanation of dopamine helped a lot. Okay, good. All right, good, you guys. Yeah, I will keep looking for kind of a simplified version of these dopamine pathways. And I think seeing like a schematic of it would help. But you're welcome. All right, have a good night.